First of all, I just want to say a couple of things about my time here in Durham. As the Vice-Chancellor said, I joined in 2005, and I can still very much remember the interview that I had in the Wolfson Research Institute. After the interview, I was told maybe I should have a wander around the campus and see what it was like while the panel had their deliberations. And the campus then was very different from how I believe it is today. There were very few students and staff, very few cars in the car park, no cafe aroma. And I seemed to wander off into what could be described as a bit of a deindustrialised wasteland. And after my appointment, I saw in John Snow College that actually I was following the footsteps of someone rather more famous and influential than myself. And of course, this is Margaret Thatcher's famous walk in the wilderness from 1987, when she came up here to Teesside to see the effects of the monetarism policy on employment and work in the North East. Now, this deindustrialised landscape has been particularly important for my work here at Durham for two reasons. Firstly, I've been based here at Queen's Campus, which is a really good example of successful regeneration and the role that universities like Durham can have in that. And secondly, because it's formed a very visual and vivid backdrop for me in terms of inspiring my own research. There's nothing quite so obvious to me from a kind of geographic perspective as the role of deindustrialisation and the importance it has had in the North East for the lives of people and communities. And of course, my particular interest is around the role that work, or indeed lack of work, has on people's health and indeed health inequalities across the country and internationally. And I'm going to talk about that from what I call a political economy of health perspective. In public health and medicine, there's been a long tradition of thinking about the political side of health, how politics and the economy impact on people's health. And here's a very famous quote from Rudolf Virchow, talking about how medicine is a social science, something we definitely agree with here at Durham, but also that politics is nothing else but medicine on a large scale. This kind of message has been taken forward in research in recent years by people such as Vicente Navarro, Nancy Krieger, and I like to think that my own work is working within this kind of field of inquiry. So today I want to talk about two central ideas. Firstly, that paid work or lack of having work is the most important determinant of population health and health inequalities in what are seen as advanced market democracies. I see this, to paraphrase Michael Marmot, as the causes of the causes of the causes. And for some of you who aren't in public health, I will explain this in a little more detail shortly. And secondly, why is work so important? And I think that's because of the role that it plays within the wider political economy of health. Work is very important in terms of people's income, their status and their self-esteem, and in their ability to access goods and services that will benefit their health. So firstly, because we have quite a mixed audience today, my public health colleagues will have to forgive me, but I just want to do a kind of refresher of some of the central concepts that will be important in my talk. And firstly is obviously the issue of health inequality, something that myself and lots of other researchers at the Wolfson focus on in our everyday research and teaching. So here's a famous definition from Margaret Whitehead, who I did my postdoctoral work with back in Liverpool. She defines health inequalities as systematic differences in health between different socioeconomic groups within a society. Because they are socially produced, they are potentially avoidable and widely considered unacceptable in civilized society. So we're looking at class inequalities in health, and also the issue there about them being socially determined, and therefore they could be changed. And these are themes that will be followed through in my talk as well. Just by way of example, here's some data showing the life expectancy gap for men and women by social class. This obviously gives a longitudinal view. But if we look, we can see towards the end, this is from 2001, the life expectancy between lowest class males and the more professional classes is 8.4 years. And we can also see that it's a less of a gap for women. There's also a slight trend towards increasing inequalities. Another example here shows how geography is important as well. This is taken from the Marmot Review of Health Inequalities from 2010. And we can see here, again, a class inequality in terms of mortality rates, with higher managerial and professional workers having a much lower mortality rate than people in routine and manual jobs. But the two different colours represent the northeast and the southwest. And we can see with the light green that in the northeast, the inequalities are higher by social class than they are in the southwest. So there's some other things going on. It's not geographically consistent. Another bit of Health Inequalities 101, so do forgive me, colleagues who know all of this, is just talking about how do we explain health inequalities. And I've just picked out what I consider to be four of the main kind of theories in this area. So firstly, the behavioural cultural model that looks at health inequalities in terms of health behaviours. So the theory here would be that people in lower socioeconomic groups are more likely to smoke, eat badly and abuse alcohol than people in professional groups. I see this as looking very much at the micro end of what could be determining people's health. In terms of a materialist perspective, I think this begins to look more macro, but it's still perhaps at a meso level. And they give primacy to income and what it enables, so in terms of what you can buy that might be beneficial for your health, but also in terms of people's exposure to material risk factors. And my example when we come on to this will be the physical work environment. A very prominent theory at the moment, one that Michael Marmot's particularly associated with, is the psychosocial model of health. And this is not just about the income, but it's about how having less income or being in a lower class position makes you feel, and that there are biological stress responses which over time, these feelings of subordination can have an impact on people's health, particularly, for example, in terms of coronary heart disease. And again, I'll touch upon this when I talk about the psychosocial work environment. And finally, what I consider to be a more macro and overarching theory is the political economy perspective, one which I see my own work fitting in. This, I believe, combines aspects of materialist and the psychosocial explanations, but it also looks above these social determinants to the wider way in which society is structured. So looking at things like labour markets, welfare state provision, regulation, and so forth. Finally, on the 101, this is a way of representing the social determinants of health. So when I was talking about the micro level, I was talking here in terms of individual lifestyle factors. And then the meso levels are the living and working conditions, and the macro, where the political economy comes in, is in the blue. And we can see here also in the green that the work environment and unemployment features, two things which I'll be talking about. But I think they're more important than the other ones within this diagram. Unemployment obviously influences, for example, access to healthcare services via income, etc. But this is just to sort of help some of my guests get up to speed before we go into the meat. So in terms of my own interests, it's very much, as I've said, around work and worklessness. And I'm going to talk through ways in which I believe these contribute importantly to health, but also to health inequalities. So I'll talk about the physical work environment, the psychosocial work environment. I'll then look at lack of work in terms of unemployment and health-related worklessness, for example, incapacity benefit receipt. I'll then take a comparative perspective, looking at whether the relationships we see here in Britain are also shared by our European partners. And then finally, I want to talk about what can be done, because I do believe it's important for research, particularly in this area, to have impact on policy and practice. So in terms of the physical work environment, I think we can all sort of think of images from the 19th century of the cotton mill workers and the lung diseases that they had. But there's been a lot of loss of kind of focus in mainstream public health on the physical work environment. I think there was a feeling that health and safety regulation, deindustrialisation, and indeed the emerging problems of the psychosocial work environment have replaced the physical work environment as an important source of ill health. However, when researching for my book, it became clear that there was still a significant minority of workers in the UK and also in Europe who were still exposed to potentially hazardous physical work conditions. And the most important aspect is, of course, that this is socially patterned, so there's inequalities in exposure to these risk factors. So what risk factors? Here are some examples of what I'm talking about. So, for example, handling dangerous chemicals, noise or vibrations in the work environment, or ergonomic factors, repetitive work, shift work, for example. And here this just gives some data to show the percentage of the European Union workforce that experience regular exposure to these hazards. The sort of high-risk jobs. So again, we can see certain ones appearing, and they do seem to be ones that are lower skilled work, lower paid work. And also the sort of diseases that come about. So for example, with vibrations, there's vibration syndrome, but also significant effects on musculoskeletal disease. So if you think of, for example, people who are driving quite a lot in vibrating tractors or coaches, etc. Shift work, again, is something that's very important, and we can see here that almost 20% of the EU workforce are working on shifts, and night work is particularly problematic in terms of cardiovascular disease, injuries, etc. So the physical work environment, I'm not going to pretend it's not better, it obviously is, but I'm saying it's still an important exposure for a certain percentage of the workforce across Europe. And I think it has an important part to play in health inequalities for two reasons. Firstly, the exposure to these hazards is greater. And then, of course, inevitably, that means that we have higher health problems as a result of the physical work environment for people who are lower skilled as opposed to people in the higher professional groups. And here's some example of some EU data which shows regular exposure. And I've just got the top two occupational groups compared to the bottom two. And we can see here that, for example, there's almost a doubling of exposure, as you might expect, in terms of handling chemical substances, but that this is also the case for things like shift work. And the other issue, of course, is that for people, they're not necessarily just handling chemical substances, they may also be exposed to noise and heavy loads, all within the same job, all within the same work environment. So the physical work environment, I think, poses still an important element within this big question of how do we explain health inequalities. And here's an example of the actual health effects. So we've seen the differences in exposure, and here's an example in terms of differences by a health outcome. Here I'm looking at injury rates in the UK, and again, the top two groups versus the bottom two groups. And we can see again a huge increase amongst those working in less skilled, routine manual jobs, especially even compared to all occupations. So there are significant inequalities in workplace injuries. So that's the physical work environment. So we have that on the one hand. What else is going on? A lot of us here, academics, teachers, people working in local government and public health, probably do not have much exposure to the sort of physical hazards I've been talking about there. However, the psychosocial work environment is something that public health's been looking at for the past 30 years, particularly in terms of the Whitehall studies led by Michael Marmot. And the psychosocial work environment and interest there came alongside the decline of manufacturing, the deindustrialisation, and the move in Britain towards a more service-based economy. So public health's focus also moved, and this is very much focused on the idea of stress and health. So you've probably picked up on some of these ideas in your own work or indeed in the media. One of the most important theories that I'm going to talk about is the demand control support model associated with Karasak and Theorel. But one thing to also think about in this context is the role of alienation at work. And there have been critiques of the psychosocial theories that they forget about the material conditions in which people work, and that actually what we call psychosocial work environment could also actually be an element of people's alienation. Lack of control at work could lead or be a part of alienation. So here's the demand control support model. We can see on the diagram, I've tried to show visually how different types of jobs can have an impact in terms of people's stress. So for example, I would see myself as having high demands as the acting director of the Wolfson. And I would also see myself as having high control. So for example, I might get various emails from the Vice-Chancellor or from the Pro-Vice-Chancellor of Research telling me to do certain tasks, but generally speaking, unless there's an emergency, I have control over the order in which I do those tasks, and indeed if I wish to do them at midnight, I can also do that. So I have an active job, and a lot of academics would come into that category. On the other hand, you can have jobs where you still have the high demands, and they may not necessarily be the sort of demands that I have. That might be demands of a production line or demands of constantly having to pick up your phone in a call centre, for example. But where you don't actually have much control. So it is, you're being controlled almost by the machines, for example. And this is what we talk about when we talk about high-stress jobs. And it's these high-stress jobs that are more likely to be amongst people who are lower skilled employment as opposed to the active jobs. And the high-stress jobs have been associated with a number of adverse health outcomes. There's a very strong literature showing the relationship with cardiovascular disease, for example. Also, an emerging literature in connection with obesity. Good literature in terms of musculoskeletal pain and lower back pain. And also in terms of mental health, where there's around a third increased risk of psychiatric disorders for people who are exposed to stressful work environments as opposed to those who aren't. So how does this play on health inequalities? There is a kind of reoccurring theme. Again, the exposure is much higher amongst lower skilled workers. And here's some examples. Here we can see, this is taken from Health Study of England data, which is based on some work that Marmot and Wilkinson's done. And it shows here the higher bars in the light grey are low variety at work, and the white is the low control at work. And we can see, starting with class 1 as the professional groups, going down to your unskilled manual, that lack of variety at work and low control at work is much higher amongst these groups. And there's a clear gradient in terms of this exposure. And what did they find when they looked at the role that this had in terms of people's health? Well, an example is in terms of coronary heart disease. The work environment, the psychosocial work environment and the stress that resulted from that was a more important factor in explaining health inequalities in cardiovascular disease than adjustment for what would be seen as traditional factors. So, for example, smoking, diet or alcohol. So inequalities, about 64% of the health inequalities in men were accounted for by these differences in exposure to stressful work environments. So again, an important factor in this wicked issue, to quote my former colleague Tim Blackman, of health inequalities. So it doesn't look like work's too good. What about if you don't have a job? I'm afraid it's not quite the case that you're going to do better. And there's been a long-standing knowledge about the role of unemployment in relationship to having poor health outcomes. And you can see that I've stolen a picture here from Picture Stockton. I apologise to the leader of the council, who I know is here. But I'm sure he'll also be pleased that it is a picture of McGonigal. McGonigal was a chief medical officer here in the local authority, working in the 1930s in Stockton, and was very pioneering. And he did one of the first studies to look at the relationship between unemployment and mortality. And he found that roughly men who were unemployed were twice as likely to die as those that were in employment in that period. And his research has actually stood the test of time. So much more recent research from the 80s and 90s also reinforces this roughly doubling effect of the risk for mortality from being unemployed. And you can see also from what I've listed there in terms of worse health behaviour, so people are more likely to smoke or drink. Their effects extend to families. So the death rates of families of unemployed people are higher than those of the employed. And one thing perhaps that's a query around this and that's still not been answered is whether the mechanisms behind the relationship between unemployment and health are psychosocial, as we've talked about, in terms of people's lack of self-worth, loss of a role, etc., or whether they're material, so in terms of the amount of money they've lost by not being in work. It's also worth noting as well that there's a new sort of literature in public health responding to flexible labour markets that looks at insecure and precarious work. And here you can see that for people who have insecure employment, they actually have mortality rates that are about a fifth higher than those who have a permanent contract. So it's not just unemployment that can be bad for health, but having uncertainty. So again, this builds on the stress model of population health. I just want to give an example. Here's some data again taken from the Marmot review, which shows the differences in mortality rate for people who were measured in 1981. So we have in the dark green people who were employed, And again, there's the social class, 1 being the highest. And then we can compare them to people who were unemployed, again with social class there. So we can see, regardless of your social class position, unemployment has a huge effect on the likelihood of dying. But also, there is still a gradient in both the unemployed and the employed. So the health inequalities persist even within what could be seen as a vulnerable group in health terms. So I looked with a colleague at how important was unemployment in terms of explaining health inequalities. And one issue is the fact that unemployment does tend to be concentrated in lower socioeconomic groups. So, for example, we showed the chart there of mortality rates, but we didn't actually show in terms of the numbers. So, for example, using census data from London, over 80% of women with a degree were employed, but only 50% of women with no qualifications. And of course, this was in a period where the economy was doing relatively well. And what we did was we looked at ill health, comparing men and women, but I'll give an example here of men. If we looked at men in terms of whether they owned a house or whether they were renting, we could see that male homeowners had a 5.6% ill health, but that compared to almost 20% reporting of ill health for people who were socially renting. So a 13% difference. Once we adjusted for the employment rates of these different groups, there was only a 2.5% difference in terms of people's reporting of ill health. So an 81% reduction in the inequality. So the employment status here accounted for over 80% of that socioeconomic inequality. I have a way of representing it here. This is using a slightly different measure of inequality. We're using the educational qualifications. And we can see here that for men, we're comparing here to the top level. So 4 and 5 is your degree. And then down at the bottom, we've got men with no qualifications. In the dark, you can see the prevalence of their ill health. This is self-reported general health. And we can see a clear gradient. Once we adjust for whether people are employed or not, this gradient reduces massively to the pale grey. So unemployment is accounting for all of that difference. And thinking back to the earlier graph that I showed of the difference between the southwest in terms of inequalities and the northeast in terms of inequalities, my conjecture would be that the unemployment and worklessness rates in the northeast could well be contributing to those differences in inequalities across the country. This is the same, but again for women, and we see the same patterning in terms of the reduction of inequalities if unemployment was dealt with. So that's unemployment. One of the more recent, semi-recent issues, and certainly one of the very popular issues at the moment, is the issue of health-related long-term worklessness. So it's different from unemployment, which tends to be more cyclical, hence we're experiencing large increases in unemployment at the moment. But worklessness is something that I see as more structural. And again, back to this idea of deindustrialisation, we've seen a huge increase in structural worklessness since the late 1970s, particularly in places like the Northeast or Wales, for example. So, as we know, ill health itself can result in unemployment or worklessness. And for example, in the UK, if people have a health problem and cannot work, they receive benefits such as incapacity benefit. So of course, this has become an important policy issue because fairly steadily, actually, over the last 20 years, there's been around 2.5 or so million people who have been in receipt of these benefits. And EU data shows that people who develop health problems are more than twice as likely over a 4-year period to become unemployed, out of work, than people who don't have health problems. So it's not something that's necessarily going to be easy to tackle. But how does it contribute to inequalities? Now, because I'm in a geography department, I felt obliged for my head of department to provide a map. And this is actually based on some of my own work as well. Shocker. And here we can see standardised illness ratios using incapacity benefit claims, and we can see the paler areas are areas that have below average rates of incapacity benefit, and the darker areas are those with above. And unfortunately, as usual, the northeast comes out as a bit of a black spot up there with very high above average illness ratios in relation to incapacity benefit. So there's spatial inequalities, but there's also socioeconomic inequalities. And by that I mean that there are big educational inequalities in terms of the employment rates of people with ill health. And I think this situation has worsened since the 1980s, so again, tying into this issue of deindustrialisation and the loss of lower skilled jobs. So here's an example of some research by colleagues at Liverpool, Margaret Whitehead and co. And they looked at the employment rates of working age people, comparing people with ill health problems and people without, and also putting in a socio-economic class element. And here you can see, if you look at the top line, that for men, people who had a low education and had ill health, even compared to their kind of co-workers who were similarly poor in terms of education but were healthy, the difference for them is around 50%. So they're 50% less likely to be employed if they have a health problem than if they don't. And that was in the mid-80s. We can see that this situation has worsened because they're actually 65% less likely to have a job now. Interestingly, these patterns carry on across, but in terms of what you might see as the biggest divide, high education and healthy versus low education ill, the pattern isn't necessarily it's not much higher than it is for the low education group. And I personally would have expected to be a bigger gap. But nonetheless, we can see that ill health is a problem in terms of employment, and it's particularly a problem if you're low skilled or low educated. So as I said in the introduction, this is very much a situation. I've drawn on EU data, but I've focused very much on England and the North East. So unemployment, the work environment, stress, they're all important determinants of health inequalities. At least that's my thesis. But how does it compare? What can we learn from other countries? And another strand to my research has been looking at comparing the health and health inequalities of different types of country using the concept of welfare state regimes. And here I've just put up a typology that tends to be used in public health, and this is from Ferreira. And we can see, for example, that Ireland and the UK are in the Anglo-Saxon group, whereas we have a Scandinavian group, a Southern European group, and a broadly Central Western European group. And these groups of countries are put together because of their similarities in terms of their approach to the economy and in terms of the welfare state provision. So, for example, the UK would be seen as a very liberal, light touch, laissez-faire kind of economy with low levels of out-of-work benefits, for example, which may be important for people who are unemployed. In contrast, the Scandinavian and Bismarckian countries tend to have more generous benefits, higher levels of regulation and so forth, although based on different principles. Bismarckian tends to be insurance-based and Scandinavian tends to be universal and funded through taxation. These are, of course, very big generalisations, and there's a huge debate, as you might imagine, as to which country goes where, but I shan't bore you with that today, but happy to take questions. And what I want to do is to explore the issues that I've talked about around the work environment and lack of work in terms of what's the role of these different mechanisms, what difference can a state make to these relationships that we're seeing in epidemiology. And a colleague of mine, Nico Dragano from Germany, did a comparative study looking at stressful work environments. This was particularly amongst older European adults, people over the age of 50. And they found that across Europe, if you had a high-stress job, you were twice as likely to have mental ill health. But that the likelihood of mental ill health was actually greatest in the Anglo-Saxon countries, so greater in England than it would be in some of the other countries, and that the risk was lower in the Scandinavian countries. So they concluded that the type of country, the type of economy that you belonged to really mattered, and that it accounted for up to 75% of the differences between countries in terms of stress levels, and also obviously in terms of therefore the health effects of that stress. So there's something going on in Scandinavia that makes it a less stressful environment. The second example is some work that I did with a colleague from the Erasmus Medical Centre in Rotterdam. And we did a similar analysis, but looking at unemployment and health. And again, we found a consistent negative relationship between unemployment and health. So you're going to have worse health if you're unemployed, whether you're in Sweden or whether you're in England. That doesn't matter. But what matters is the inequalities, the size of the inequalities. So they were largest in the Anglo-Saxon countries, larger in Britain than they were in the other countries. So you're more likely to be ill if you're unemployed in England than you are in Sweden. Some research by an American, Rodriguez, compared benefit rates amongst unemployed. So looking at the amount of money and how people got money. And they compared the UK, Germany, and the USA. So 3 fairly different countries. And they found that people who were getting lower levels of means-tested benefit were more likely to report health problems than people who were getting higher level benefits as a right of their citizenship. So there's 2 factors there, perhaps the psychosocial in terms of whether you're getting a benefit that's seen as a bit stigmatized, a means-tested benefit, and then as opposed to one that you get as an entitlement, as a right of being a citizen. But then there's also the issue of how much those benefits are worth. So again, this material aspect of unemployment and health. So again, it doesn't answer that question of what causes the relationship between unemployment and health, but it does again illustrate issues about how different countries tackle unemployment. In terms of ill health-related worklessness, Van der Velde, who works in Norway, he compared across Europe again, looking at people with health problems, and he found that across Europe, people who have health problems are going to have a lower employment rate than those who are healthy, so reinforcing the UK data that I presented earlier. However, they found that, again, there were differences by type of country, by type of economy. So Scandinavian countries, because they were investing in active labour market policies, supporting, retraining, helping people get back into work, actually had higher employment rates than countries such as Britain, who were spending much less per head of population on active labour market policies. So we can see there the differences in employment rates for people who have a health problem. 62% in the Scandinavian countries on average, as opposed to 43% in Britain and Ireland. There's been a very important study the last couple of years by Stuckler and colleagues from Cambridge, which looked at the relationship between suicide rates and unemployment. Now, it's a well-known association that as unemployment goes up at the macro country level, the suicide rates also go up. There's a very high correlation. However, in Sweden, this correlation has dropped away. So there's no longer such a strong relationship between rising unemployment and an inevitable rise in suicide rates. And again, their analysis suggested that this was because of funding active labour market policies. That doesn't necessarily mean giving money in people's pockets. What it means is giving them opportunities and giving them hope, in my opinion. So all of this work has led me to put together a framework for how I understand the political economy of health, looking at work, the state, the wider politics and the economic system. So this comparative perspective applied over to perhaps more everyday experiences of work and ill health. And from this I have put that work, labour market structures, etc., within a society have an influence on how socioeconomic class is experienced and defined, and of course socioeconomic class itself has an impact on how people are exposed to the social determinants of health, and I believe that this then leads to the health inequality. So in terms of the what can be done, I think there are various intervention points as I'd see as primary, secondary and treatment. And the main one from my perspective, looking at this comparative work, would be at this point A, at the macro level. So looking at how the economic system, how the state in terms of the welfare state, how they engage with people, how work is regulated and so forth. The second point would be more in terms of the meso-level social determinants of health that we looked at, housing, the environment and so on. And then intervention point C, I see more as a treatment. So what do we do about health inequalities now? They're here. How can we treat them? And of course, that does lead to some, what I'd see as micro-level intervention. So obviously, helping people to stop smoking would have an impact there. And I'm not saying don't do that, but I'm just saying we also need to look up at this top end as well to prevent some of those problems happening in the first place. So it's a preventative framework in that sense. So I wanted a picture of Lenin, and I managed to craft a slide to reflect it. And this is again Rudolf Virchow, and he's talking about the medicine as a social science, as we had at the beginning, about the politics of medicine and the politics of health. And then he talks about medicine as a social science, as a science of human beings, has the obligation to point out problems and to attempt their theoretical solution. The politician, the practical anthropologist, must find the means for their actual solution. Now, I'm not sure whether Virchow would do very well under the impact agenda, because I think that we actually now need to not just be talking about the theory, as I've done there. That's nice, that's interesting, Clare, go back to your ivory tower. We also need to be practical anthropologists and find the means for solution. So I'm just going to talk through a little bit about the public health evidence, about what can we do. I've described how work or lack of work is important to health inequalities. Great, but what can we actually do here and now? And I'm sure people will be relieved to know that I'm not actually suggesting a Leninist revolution. I'm afraid we have to come rather down. And I think there's evidence from cross-national studies, etc., from workplace studies, in terms of the physical work environment, about improving health and safety legislation, putting the emphasis perhaps more on employers rather than on employees to wear protective equipment, etc., trying to reduce the exposure that workers have in the work environment to these kind of risks. More simply, there's also ergonomic strategies, quite simple things like job rotation, so people aren't engaged in repetitive work all day, but swap with a colleague, so have different things, having more breaks, etc. And shift work interventions, I've done some research here at Durham looking at whether if you change your shift working patterns, what effects can that have? And just quite simple things. If a company was using a fast rotation or a slow rotation, they'd have different health effects. It doesn't necessarily affect the ability of that employer to produce what they need to produce, but it can have an important impact on the health of the workers. Another example is the compressed working week, where staff are able to work their 40 hours over 4 days if they choose, and then have a longer weekend. We found in our research that that had beneficial health effects. Again, it doesn't necessarily have to be a huge change in terms of the wider work environment. In terms of the psychosocial work environment, one key area coming out of Sweden is in terms of the Swedish Work Environment Act, which very much set out ways in which the psychosocial work environment should be monitored and controlled, and also giving the opportunity for workers to be involved in councils and making decisions about their work environment. I was involved in some research with colleagues from Glasgow where we looked at what we called these macro-organisational changes, and participatory councils are particularly popular in the German model. They've obviously been economically successful, well, for now. And we found that if staff were able to be involved in making decisions in their work environment about their breaks, about the content of the work that they did as a team, etc., this could have beneficial effects on their health. At a more micro level, we did some research looking at how people's job variety could change. So again, it's giving people control, but also perhaps changing the demands that they're exposed to. And if you have team working rather than a solo worker, thinking of a production line, for example, if people will switch round rather than doing the same repetitive task, it obviously breaks up that kind of psychosocial demands and perhaps give people more autonomy and the chance to be skilled in various aspects of the work. In terms of the health effects of unemployment, I think drawing on Rodriguez's work and of my own comparative work, it does suggest that more generous benefit levels are required, and that also it should be entitlement rather than means tested. This was emphasised in the Marmot Review, drawing on work from Jodie Morris, which talks about a minimum income for healthy living. So if you're talking about what is the amount of money required to have per week to be able to have a good standard of health, then the benefit levels in the UK are nowhere near achieving that. And that was something that was very strongly noted in the Marmot Review to the government. I think there's also quite clear evidence from the comparative work that active labour market policies can improve people's health. That came out of the Stuckler data in terms of suicides, for example. But there is a bit of a debate here about people who are positive about welfare to work and active labour market policies and people who aren't. And often this can depend on the nature of the intervention. Welfare to work's a big term. It covers lots of different things. And what they're doing in Stockholm or Copenhagen may be very different in content from what's perhaps happening in the UK. And there are also concerns about, particularly in an environment as we are in now economically, whether there are actually jobs for people to go to at the end of these programmes, and whether that kind of empowerment that might come alongside welfare to work and that might improve people's health could be a bit of a false dawn. But that, of course, would be another talk which I might give another year. In terms of people who are out of work due to health problems, again, it's this idea of active labour market policies, looking at different things that you can do to help people become more skilled, more attractive to employers. But I think there's also a need to increase the demand for people who have health problems and to increase engagement with employers so that they understand the benefits that they might get. There's done a lot of research in this area. I've been involved in some of it myself in terms of looking at effectiveness. I did a report for the Department of Work and Pensions, and actually we found that the programmes in the UK, it was very unclear as to whether they were effective or not. And some work that I've been doing with County Durham Primary Care Trust, looking at an intervention to improve the health of people who are out of work initially, rather than putting them straight onto an educational training programme, is beginning to show positive effects. So I'm arguing now for a health-first approach. So improve the health and then deal with the other problems that there may be afterwards. So that's my thinking on how we can change that situation. So in my sort of concluding comments, I think my main thesis is that we have these important meso-level determinants of health inequalities, and I think it's the work environment, both physical and psychosocial, or indeed the lack of work that people experience. And because of the differences in terms of socioeconomic class, more likely to be unemployed if you're lower skilled, more likely to have a stressful job, more likely to be exposed to hazardous physical environments, and more likely to lose your job if you suffer ill health. That these are very important determinants of health inequalities. The comparative work I've been engaged in shows that actually the wider political economy of the welfare state can have an impact on this in terms of lessening exposure and therefore reducing the health impact of work and worklessness. So my conclusion, and I do hope it has an impact, but I'm not sure it will, is that reducing health inequalities requires the creation of good quality, secure jobs alongside a more supportive, health-first social security system. And to finish, I'm not going to pretend that any of my ideas are particularly new. This is William Morris talking about work and health in 1884, and I think he perhaps puts a lot more neatly than me my basic thesis for this lecture. And I'll leave it there.